You're watching CTOM TV. Knowledge is power.
I think it's important now to go over indicators of responses.
Okay, indicators of responses. So
And
how do we know it's working? Is layperson's
or what we would use to justify giving a patient a PD-1 inhibitor.
Okay.
Now, these have changed. Most facilities that use PD-1 inhibitors or CTLA-4 inhibitors, most of the emphasis on PD-1 inhibitors, will focus on one or two different features.
Okay.
And so the first one that we ever discovered was called high PD-1L. And so we used to do a test. We found that if you have high PD-L1, then you have a much better chance of responding to PD-1 inhibitors.
Mm-hmm.
Now, that was started in melanoma and certain cancers.
Mm.
Now, as we go through different cancers, we find that not all cancers is PD-L1, high PD-L1, an important indicator of response.
Okay.
So in certain cancers, you can have high PD-L1 and not get any response.
Mm.
Or other cancers, you can have no PD-L1 response or no PD-L1 and have a very high cancer, benefit from this drug.
From the pembrolizumab.
Right. So we used to use liquid biopsies to look at body-wide expression, and that was much more effective than just looking at a single tumor. But once again, it's cancer specific. I'm not going to get into which cancers because there's just too many of them to go over.
Mm-hmm.
The other one is mutations in a process called DNA damage repair.
Mm.
This is a series of genes that repair mutations. So if you have mutations in this class of genes, then you're probably going to have a good response to these PD-1 inhibitors or CTLA-4 inhibitors.
Mm.
Another indicator of response is what we call microsatellite instability, MSI. And so for most clinical trials that use, or most doctors that use PD-1 inhibitors, they'll look at the PD-1, they'll also look at the MSI, and they'll look at the mismatch repair, and they'll also, as of recently, look at what's called the tumor mutation burden.
Mm.
These are the four that are really used mostly these days. So high PD-1, high MSI, and basically what MSI is microsatellite instability, and that just is, we have these markers called microsatellites throughout our body. They're used for paternity testing. They're used to determine they're used in forensics to determine differences between people, or if people are related to each other, then you have similar microsatellites. Microsatellites in every person are unique, with the exception of twins and family members. You have certain microsatellites that are similar.
Okay. To your biological relatives.
Exactly.
Or close biological.
And that's how these tests can be used to determine paternity.
Mm.
So if you have a high amount of microsatellite instability, then you're going to have a good response to PD-1 inhibitors.
Okay.
And that is likely because the tumors are going to look the tumor cells are going to look a lot more different than the normal cells in the body.
Okay. They'll stand out more.
They'll stand out more because of this microsatellite instability.
Okay.
Then changes in or mutations in the mismatch repair process. That's a process that repairs DNA.
Okay.
And then the amount of tumor mutations in your tumor.
Mm-hmm. That's the tumor mutation burden.
Yeah, so if you have a high amount of mutations, then it's going to be easier for your immune system to recognize tumors and differentiate them.
Okay. Mm.
So there's actually an equation that we used for a while to determine tumor mutation burden.
Okay.
There's many different ways of doing it now, but there's an actual equation where you can you take the amount of coding mutations per megabase, and you punch it into this equation, and it tells you whether you have high tumor mutation burden, moderate, or low.
Okay.
Now, very recently, we've used tumor mutation burden for a long time because it was a very good heuristic. But recently in lung cancers, we found that tumor mutation burden does not indicate a response, which is quite interesting.
So it doesn't not indicate a response either, meaning
no,
either...
it just you'll have a much. We used to think that anything with high tumor mutation burden, in fact, high tumor mutation burden is an FDA indication, an FDA approved indication to let you know whether you can use a PD-1 inhibitor. But now we're starting to see that not all cancers, just because they have high tumor mutation burden, are going to have a good response to it.
Right.
So lung cancer is one of those now.
So right there, I feel the need to interject, because this is something that comes up a lot with the clients that you support, really, is that there's current science that says, no, that's not an indicator. But your oncologist is almost certainly operating on the old information. So it's very important to be able to have the data to present to them to say, for you to have confidence in your treatment, but also for them to have confidence in prescribing certain things or not prescribing certain things to you, to have the most current data, really, which very few practicing oncologists will have.
Well, I think what I really wanted to show in this aspect of the presentation, or this component of it, was that it is so unique and specific to every person. It truly is precision oncology. And we're going to see that in some other examples, how personalized these indicators of response or lack of response are. They're specific to the mutations, they're specific to the person and the type of cancer. So you cannot generalize with these drugs. You need to know exactly what your tumor makeup is. You know, you really need to have tumor DNA sequencing in order to determine if immunotherapy is going to benefit you or not.
Thank you for watching Ketome TV. Subscribe below and stay informed.